Hello and welcome to the Complex Care Journal Club podcast. My name is Kathleen Huth. I am a pediatrician at Boston Children's Hospital and your host for this episode. In this podcast series, we seek to discuss emerging evidence in the care of children with medical complexity and its implications for practice. I'm delighted to have Dr. Jody Lin from the University of Utah joining me today. She is the lead author of the article, Caregiver Values and Preferences Related to Surgical Decision-Making for Children with Medical Complexity, published in Journal of Pediatrics in January 2025. Jody, thank you so much for being here.
Thank you so much for having me. I'm really excited to share with you today the work that we've done on this paper. So the motivation for this paper is really around how can we help support families better throughout the lifetime of caring for children with medical complexity. One of the things that really stands out to me when I think about the care for children with medical complexity are the numerous high-stakes decisions that they have to make throughout their lifespan. And it's really that has motivated a lot of the work that we have done. There's a limited evidence base for guiding these critical decisions. And what we know is that in general, when people are faced with high-stakes decisions with limited evidence base, they tend to skew towards high-intensity interventions, even when lower-intensity interventions are just as appropriate. Shared decision-making is a communication process in which caregivers, patients, and providers can share their knowledge, preferences, and values to reach treatment plan agreement. And if shared decision-making is done well, ideally the decisions that are being made fit the unique values and preferences of each family. We also know that parents of children with medical complexity overall desire higher quality shared decision-making in these high-stakes decisions. And one of the gaps is understanding what preferences and values are important to caregivers during these complex decisions. A lot of our work thus far has used the decision about whether to undergo surgery for neuromuscular scoliosis as a test case for understanding how better to support these families. The objective of this study was to describe the parent preferences and values that inform treatment decision-making in the care of children with neuromuscular scoliosis.
You've done some work related to shared decision-making for children with medical complexity and their families. I saw a paper in Academic Pediatrics talking about that in general. I'm curious, how did this particular context or study come to be, and how does it build on the work you've done before?
Yeah, great question. So clinically, I've been really interested in this as a hospitalist. I think because we care so much for these children in the postoperative period for surgical decisions, or we have a lot of complex decisions that we speak with families about as they're making those decisions. And because of that, I was inspired to look at neuromuscular scoliosis treatment as one of those decisions where I had clinically experienced some really powerful patient experiences that made me question whether the care that we were delivering was truly the best that we could provide families. And so on that journey, kind of two fortuitous discoveries happened early in my career. One was the Academic Pediatrics article that you referenced, where we interviewed parents around their experiences making decisions for their child, uncovered two areas that we are currently not doing well as clinicians. One is really understanding and inviting families to share their preferences and values during decision-making conversations. And the other piece is understanding the uncertainty and how to help families navigate uncertainty related to those decisions. The second research activity that led me down this path was that I did a cost-effectiveness analysis of neuromuscular scoliosis treatment options while I was still undergoing my training as part of my master's coursework. And what we discovered through that cost-effectiveness analysis was that surgical treatment decision is what we call preference sensitive. So what that means is it could be cost-effective, but it's entirely dependent on what's important to the families to guide whether or not this is cost effective. And so that's a really compelling reason then to think about how to devise a intervention that can help elevate caregiver preferences and values. Bringing those discoveries together really was what inspired this work, because at the end of those two experiences, I really thought about the, what next? And I think that there is a lot of robust literature in the decision aid world on how to create what are called values clarification exercises to help parents and patients identify their preferences and values. But when you look at kind of how those are structured within the context of children with medical complexity, many of those exercises do not account for the heterogeneity of conditions and the heterogeneity of preferences and values that families of children with medical complexity face. So we can't necessarily do an experiment where we only have, 5 preferences and values to evaluate. And so this study is really a starting point for us to rethink how to do values clarification in a way that's suitable for children with medical complexity.
Thank you for sharing some of that background. I think people really appreciate hearing the road to the research as well. Can you tell us about what you did for this study and some of your key findings?
So for this study, we conducted semi-structured interviews with caregivers of children with neuromuscular scoliosis. These caregivers had to be adults, so 18 or older, and be able to be interviewed in English or Spanish. We defined neuromuscular scoliosis based off of seeing neuromuscular scoliosis in their chart or seeing scoliosis and some underlying neurologic or neuromuscular condition. And then we used chart review to confirm that these children did in fact have neuromuscular scoliosis. We excluded children who were less than 8 years of age when they made the decision about whether to undergo surgery, because that usually indicates more of an atypical case, because that means that their scoliosis progressed very rapidly. And then we also excluded people who were less than 6 months out from surgery if they chose surgery, just because there's a lot going on during that initial post-operative recovery period. And so that could really bias their experiences. We also didn't want to further stress families during a very tough recovery period. We did some purposive sampling to try to get diversity of experiences as well as geographic diversity and language diversity. And we recruited from 2 distinct sites. So University of Utah / Primary Children's Hospital here in Salt Lake and Children's Hospital Los Angeles out in California. We conducted an inductive thematic analysis using modified grounded theory. And we had 2 separate coders code each of the transcripts with serial coding reviews to develop an initial code book and then subsequent reviews of codes and memos to further develop the code book and eventually synthesize our themes. And we finalized themes with a series of larger team meetings with the rest of the study team. For the Spanish interviews, we were lucky that we had people who were fluent in Spanish. And so we had one coder who was had native level fluency in Spanish, analyze the transcripts in Spanish. And then I do not have native Spanish language fluency. So I analyzed the translated transcripts in English, and we did the same process of codebook development and analysis for those Spanish transcripts as well.
I thought that was actually a really nice feature of your methods. The fact that you both did the purposeful sampling to sort of understand if those experiences were substantively different for Spanish-speaking families, but also the fact that you did the interviewing and analyzing and coding in Spanish is a really nice model for ensuring that lived experience is incorporated.
For us, it was really important for this work, and it's important for the work going forward, particularly when we think about Spanish language as the most common non-English language that's preferred. And within the decision-making literature, I think people have tried to create bilingual or multilingual decision aids, but mostly that has been, send the English version over to translation after the fact. And so it's really important for our lab that we're deeply committed to understanding how to truly make bilingual or multilingual materials. And so interviewing participants in Spanish, doing analysis in Spanish language was really the starting point for us on this journey.
So what did you find in your study?
So we conducted 44 interviews, 9 of which were Spanish. And the short of it is we found numerous preferences and values. It was a lot to sort through and quite daunting, but also not surprising in terms of the variety of things that were important to people. There were a few themes that occurred. Some we identified as related to values. So really things that are important to people as they're thinking about the decision, and other themes related to what's called preference formation. So how do they, at the end of the day, end up deciding which treatment option they prefer? So first, thinking about the themes related to values. So there were things that, were not surprising: reducing pain, concerns about how scoliosis could affect their child's underlying breathing, the immense impact of comorbidities in all of this decision making. I think the one value that I thought was particularly interesting was around mobility. So when I think of neuromuscular scoliosis treatment decisions and mobility, I primarily think about wheelchair fit and the child's baseline ability to ambulate, and how scoliosis is affecting those two things. But the way that parents thought about mobility was much more complex. They mostly tied mobility to the child's socio-emotional quality of life. And to me, that was really striking. If a child can't fit well in their wheelchair, or if a child can't lift their head up to meet you at eye level, that substantially impacts their ability to relate to their peers, their desire to go to school, go out to the park, to really do any sort of interaction with the world, because that physical barrier of how they're fitting into the wheelchair, or their ability to be comfortable sitting in class without pain, to focus on interacting with their peers and understanding what's being taught. And I thought that was really an important reminder as a clinician that it's not talking necessarily about the technical aspects of wheelchair fit. It's understanding, what does that look like for this child? And that really helped me understand the motivation behind doing surgery. In terms of the themes related to preference formation, so there were the typical things such as, wanting more information from peers, increasing decision-related knowledge. There were two other aspects that I think were really important and less recognized. One is this concept of decisional self-efficacy. So decisional self-efficacy is really about, if I make this decision, do I have the capability to adhere to that decision? So during the recovery process for neuromuscular scoliosis, there are limitations to how you can transfer a child, and there's changes to their mobility from just having a spine straightened. So not only are they taller, there are some limitations depending on the surgery itself of whether they can bend or not. And overall, as they heal, their spine becomes fused, so their back becomes stiff. And so parents talked sometimes about how if they lived in a second-story apartment, their child could no longer go upstairs because they would use their hands to push themselves upstairs. But with a longer torso, they weren't actually able to maneuver in a way that they could move their child upstairs. And I think that's an important reminder whenever we're talking with parents to really get a comprehensive understanding of what life at home is like. The other theme that I thought was less surprising, but just more reinforcing of our prior work is the prominence of uncertainty in these decisions. So parents reinforced to us that they are constantly grappling with immense uncertainty and that unfortunately they feel very unsupported in understanding how to deal with that uncertainty in the decision-making process. And I think that's a very human thing for clinicians to avoid, right? We like to talk about the evidence and what we know. And so, of course, talking about what we don't know may feel like a major shift for us in guiding these conversations. One aspect of uncertainty that was interesting, but has also been described in other populations, is this concept of ambiguity aversion. And so what that means is that when people are faced with uncertainty, they will run to the more certain treatment option, even if that's at a higher risk for a bad outcome. So for example, if a child with neuromuscular scoliosis and their family is told, well, the curve may worsen rapidly during puberty, but we just don't know. Like time will tell, but we're going to have to sit with that uncertainty. Or you could do surgery now, but that puts your child at risk for all these other complicated post-operative risks. People tended to say, okay, that makes me really uncomfortable not knowing what the future holds. So I'm just going to do surgery now. And that wasn't true for everyone, but we definitely saw that expressed with a few caregivers. And so as clinicians, we also need to think, okay, it's not necessarily just recognizing uncertainty, but how do we represent uncertainty in a way that doesn't scare people away from it? It helps them understand what uncertainty is so that even if they were to end up making that decision to go to surgery, it's not because they're scared of the uncertainty. It's that they sat with the uncertainty, they sat with their understanding of what that means, and they still decided, at the end of the day, this surgery is still what's best for me and my child.
Thank you for that overview. What do you think are the implications for clinical practice? So specifically, what do you recommend for members of the interprofessional care team based on your findings?
Most readily, I think putting into practice assessing for decisional self-efficacy, right? Just take it as part of the questions that you ask when you're helping someone make a treatment decision of the decision that you chose will require X, Y, and Z things to happen. How difficult do you think that might be? Or what concerns might you have about being able to do those things? I think that if we just integrated that question into our routine kind of decision planning, I think that could uncover a lot of interesting things that as a hospitalist, I feel like we uncover in the scramble of like discharge planning, right? But we could have anticipated months ahead of time when this decision was being made. I think the other thing is be okay recognizing uncertainty. I wish I had more tools, but I think for now, because we don't know what are effective ways to talk about uncertainty and we don't want to try something that might end up causing more harm or causing more ambiguity aversion, I think acknowledging the uncertainty and being able to sit with families in that uncertainty can at least help families through this process.
I'm curious if you have thoughts on specific ways that clinicians can try to elicit or integrate an understanding of a whole potential range of values that might be guiding decisions. If you were to be designing either a decision aid or a value clarification exercise based on what you found, what things would you include?
That's a great question. We are in the process of trying to translate this into a tool. And so more to come in the future. But I think, adapting these themes into easily interpretable statements that get to the core of the meaning of those themes and having the parents able to identify which of those are important, I think is a first step. families are, obviously very experienced, very knowledgeable about what's important to them. But when you have so many values and preferences to think about, it is sometimes helpful to have a list. And it's not that this list is, the only list of values, but it helps generate some ideas behind what would be more important to them.
What are the messages for patients and families from your study?
I think the most important thing is that their preferences and values are crucial to guide these conversations. And so even the things that they think might not be related because they feel really non-clinical, like how is my child's school going? It's important for us to know that context because what happens outside of the clinic is way more important than what happens in the clinic. And so we need them to bring their preferences and values in a comprehensive way into these conversations. And it can be daunting with the power dynamics in a clinic setting to feel like you have to assert yourself to share these. But I think overall clinicians are well-intentioned, even though we are not perfect. And so being willing to share that can really help. And, in the meantime, I hope, our future work and the work of others can help create tools where that can flatten the power dynamic and the burden is not so much on the families to guide those conversations. But I think that patients and families sometimes feel the need to censor themselves in a clinic setting. And I would say anything that they think is important is what's important to us as clinicians, more so than, how many cc's of your feed are you taking?
One other thing that I was reading in the paper was about the importance of peer support. And I'm curious whether you think there's anything, I think that's been established in many other areas as well, but is there anything that you would suggest about sort of incorporating that into our, conversations around perioperative decision making?
The idea of having peer support integrated in decision making is a conflicted one for me. One, because I do think that there is immense power in the lived experience. And I think that, clinicians who are not also caregivers of children with medical complexity can't imagine to know, what life would really be like for these decisions. And so having peer support can really fill that gap. The difficulty is, though, that sometimes these experiences can be overly persuasive. And so this is another area that we would love to, have more work in is how do we use, narratives, patient stories in general to help inform decision making without persuading people. There's a lot that has been described about different types of narratives, outcome narratives, process narratives, et cetera. And so for us, where we would love to see people take the work around peer support is refining what the boundaries are for process narratives compared to outcome narratives, because we know outcome narratives are heavily persuasive. But I think that there's a really promising area of process narratives where you hear parents walk you through what was it like making such a difficult decision. Like, don't tell me if your child ended up doing well with the surgery or not, because we know that that's really unpredictable. But tell us how you came to the conclusion of like this treatment decision was the best for my child. I think the other thing that's really helpful that other people have described in the literature is being able to see what the process or what the function is like after a certain decision. So we've seen this in people's work around, tracheostomy decision making, for example, or asking parents about congenital heart disease decisions, those sorts of things. And so seeing what a patient looks like after surgery, seeing how their mobility changes, that can help people feel a little bit more informed about when people are saying, the child's spine is stiff after fusion, what does that mean? What does a transfer after fusion look like?
It's a really helpful distinction, the process versus outcome narrative. Sounds like that could be a really important area to kind of understand a little bit better. One thing I wanted to do a shout out to is that I know the Courageous Parents Network has some really great resources on decision making and actually about spine surgery in particular, including a decision making guide to sort of with the idea of facilitating shared decision making. And we can include the link to that with the podcast episode.
Yeah, shout out to the Courageous Parents Network. I don't think there's any other resource out there that is as strong of a resource for not only families, but also clinicians.
One thing we'd love to talk about is different opportunities or challenges that you identified while developing and conducting the study. And something that I picked up from the paper was how you had described that this was part of a larger initiative and that you were navigating two different centers. And I think it's quite a strength to have done a qualitative study across two different centers and getting those different perspectives. But it sounds like methodologically there were some differences in maybe how it needed to be carried out at each site. And I was wondering if you wanted to speak to that or other things that you encountered.
Yeah, so we were very fortunate to partner with Children's Hospital Los Angeles. This was the first study that we had done together. And luckily, because of our process in building that relationship through this project, we've continued on to additional exciting work. I also have to give credit to Tamara Simon, who has been a longtime mentor of mine, who really helped build that relationship and remained committed to this work and navigating all of the institutional hiccups together. I had a foundation grant from the Primary Children's Hospital Foundation to conduct this work. And as such, we did not have the forethought necessarily to create like a single IRB. I don't think at that point even I knew what an SIRB was. And so we did two separate IRB approvals from two institutions, and that took a lot of effort to reach a shared understanding of what needed to be done. And I think there were a few things that really stood out in that process. One was around cohort identification and recruitment. So at Primary Children's, we had great buy-in with our orthopedic partners. And so we were able to go recruit from their clinic in addition to the inpatient hospital medicine teams where I'm a clinician. And so that worked really well. We had launched at University of Utah first. So we thought we could replicate that at Children's Hospital Los Angeles. But what we found when we were trying to figure out how to identify cohorts seamlessly at CHLA was that they have a great informatics team. And so they were like, we're just going to send you a report based off of your screening criteria, and then you can reach out to them on your own time. Tamara's team was really gracious. And so they were like, well, we'll use this list, but we'll also see who's in the hospital based off of this list, because particularly for qualitative work, I think that human connection, being able to see someone when you're talking to them is really helpful in fostering connection as you're trying to approach them to talk about something that can be quite challenging to share with a stranger. The other piece around this process was also navigating COVID. So we did all of our recruitment throughout the COVID pandemic. And so they were definitely things that we did not anticipate when we set out to do this work.
Those are helpful experiences for people to learn from who are planning to do multi-center research. Any other things that you would want to share?
So there are two things that I think I learned from this experience. One is that it is so important to give parents an outlet to share their experiences. I think the reason why we were so successful in recruiting parents was because these interviews were often the only time someone asked about a really difficult experience. And so we were so lucky that families were so generous with their time and vulnerable to share their experiences. But I think talking to my research team about what was it like interviewing these families, and a lot of times they would come out from these interviews saying, I just talked to someone for 30 minutes, asking them really invasive questions, and they still wanted to keep talking to me because they said nobody had ever asked them. Nobody ever sat with them and listened to what their experiences were like.
Yeah, that's actually come up as a theme in a number of episodes, actually, about almost the therapeutic effect of eliciting some of these narratives or having that curiosity and caring to hear what those perspectives are. And I think there's a lot to be learned from that.
The other lesson that we learned was, I think, shifting what we thought was language that was patient-friendly to what really is patient-friendly. So, for example, we throw around the phrase child with medical complexity all the time. And when we first started pre-testing things, our script, our consent forms had, we're approaching you because you're a parent of a medically complex child. And people were like, whoa, whoa, whoa. Is this a new diagnosis? Or like, what is it about my child that makes them complex? And it ended up feeling like it was very hurtful for them to hear that language, even though that's the language that we use as academicians. And so changing that just to, lifelong condition, chronic condition, seemed to at least help and not shock families when we were approaching them. Or another example is with neuromuscular scoliosis, there are many potential causes. And so we would say, this is neuromuscular scoliosis is due to an underlying neurologic condition or neuromuscular condition that your child might have. And what parents were hearing was your child was born with a bad brain, and that's why they have neuromuscular scoliosis. So we ended up just taking out the explanation because it probably wasn't necessary to explain what we thought clinically was the cause for neuromuscular scoliosis. And so those two things I think were a good reminder to me of the language that we use with families is very important, and we have to be very thoughtful. And we wouldn't have picked that up had we not had pre-testing, had we not had our family advisory board members weigh in on that.
Yeah, I think that's a really nice pearl just in terms of the value of ensuring that whatever we're doing in research is both acceptable, appropriate, as well as being feasible and getting that insights before putting something into practice. I also noticed for after the fact, when you had your findings, you reported on strategies that you use to ensure trustworthiness of your analysis, including sharing it with a family advisory board that you ensured was representative. And that's, I think, a really nice strategy for people to consider using too, is to share some of the findings and ensure it has that face validity. What do you think are important next steps from your work?
For us, most immediately, we are developing a decision support tool. We're in the process of launching our first pilot of that. So I'm excited to see whether our qualitative discoveries actually bear out in an experimental setting. I think that the most important takeaway from my experiences throughout this project, as well as the body of work that we've done so far, is having true partners with families of children with medical complexity. I have learned so much from them. There are so many things that we have chosen to do as a research group that are heavily informed by the families. And I think for people who are interested in delving into research for children with medical complexity, I think that it would be really important for them to at least have an experience of either qualitative project or a co-design project where they're really interacting with families of children with medical complexity, so that they can truly understand the experiences of the families that they are studying.
I'm excited to hear that there's some follow-on work. And so thank you so much for your time, and thank you to you and your team for advancing the field of complex care.
Thank you so much for having me.
And thank you for listening to the Complex Care Journal Club podcast. We aim to highlight research that has the potential to be practice-changing, that values patient and family engagement, is relevant across disciplines and diagnoses, and uses high-quality or novel research methods. We invite you to join the conversation by suggesting an article that you would like to see discussed in this podcast using the form provided on the OPENPediatrics YouTube channel. Thank you for joining us.